specific finding. It can happen in every disease or many diseases, but which part of colon is involved? And if diffuse should be in your mind like anything. Whole of, we call it pancolitis. Pancolitis can happen, number one, UC, then C. diff, right? Of course, it can happen in infections like CMV, E. coli, etc., etc. So remember this diffuse, predominantly right side. So in this, I will particularly for your exams remember typhlitis, which happens in what we call, this one, neutropenic colitis. Previously, we used to call it typhlitis, right-sided. These patients are immunocompromised. And in the exam, they will use right-sided if not. There are other bits which are here. Left-sided, key thing to remember in left-sided ischemic, ischemic colitis. Left-sided ischemia. Number two, uh, diverticulitis. The most common uh, colitis, as far as diverticulitis, because diverticulitis can be jejunal, this, that, is sigmoid. So it has to be the left-sided. And then fancy thing, which is epiploic appendigitis. We are very specific there for diagnosis, but the management is quite conservative. So this is just from one textbook that Crohn's usually right-sided, diverticulitis and ischemia this one, typhlitis is this one, pancolitis is UC, and some, these are the most common, most common. Appendix. The main thing to remember in appendix is that appendix can be of positions is important to know. Retrocecal, which is this one, this pink one, is 64%, but there are others, post-ileal, pre-ileal, pelvic, subcecal. This is on a barium examination, enema. The appendix has been outlined. Appendicitis, of course, it's not gastroenterology world, but more interested are the surgeons. I don't have time to show you all spectrum, but the basic idea is that there is luminal dysfunction, and it all depends on the level of magnitude of inflammation. That with that, there might be perifocal stranding of fat, universal sign of inflammation. There can be an appendicolith. Appendicolith means calcification inside. And the concept is that the lumen gets obstructed, and that is why appendicitis happened. But then comes the spectrum, that there can be perforation, a localized perforation. Then more, localized perforation and slightly subacute presentation with an abscess. Then more, which is diffuse peritonitis. So all of this spectrum can happen. In this particular case, if you see, this is the appendix, this is the lumen, and there is a lith here. You see this? And where is the wall? So the wall is gone. It's not very clear. So there must be localized perforation. And with that, there is a lot of stranding and there is an abscess formation, very tiny. So this is one spectrum of appendicitis. Epiploic appendigitis. I don't think so that why is it important for you or any surgeon for you? This is a classical thing that the eye see what the mind knows. Remember this. Classical. And I have seen so many reports in my experience where radiologists miss it. Why? Because you have not seen it consciously. It's a subtle finding, but you have got the diagnosis. Usually, these patients will present with left-sided, usually left-sided pain, left side. And the classical will be diverticulitis, rule out diverticulitis, because on the left is diverticulitis. The finding is that these things, these are peritoneal, fat containing tags of peritoneum on the longitudinal muscle. The concept is that there is a central vessel which becomes thrombosed. So there is fat necrosis. And this fat necrosis you will basically see a fatty, focus surrounded by a bit of enhancement and some fat stranding. And you might see a central vessel which is thrombosed. So once you pick it up, you just say this is epiploic appendicitis. You've got the diagnosis, don't worry about anything. Don't ask for anything. Management, conservative. Management is within the peritoneal cavity, within the abdomen, there are many things which arise because of fat necrosis. Omental infarction. Is this word in your vocabulary? Omental infarction. The surgeons, I'm sure they know it. And somebody knew it. Omental, same pathophysiology is the same. There will be necrosis of a vessel, sorry, thrombosis and fat necrosis. Management, conservative. Management is conservative. Usually, even falciform ligament, you remember there is a ligament here. It can present with fat necrosis. But this is why I'm showing you the eye see what the mind knows. Sometimes, believe me, I've got calls from surgeons that this was reported as normal. Can you please review for me? Is this appendicitis? And said yes, and there you've got your diagnosis. Okay, now this is a classical exam case, absolute classical. Say again. Let pipe. Let pipe. What? Let pipe occurs in. You see, how does it occur? Think histology. You remember, I warn you that in UC, the ulcers are superficial. They are not deep. So in Crohn's, so many things can happen. It can go right and left, fistula, fibrosis. But why in UC? Loss of right and oh, good. So I told you the histology, right? How? So make your pathology, know your pathology, make your radiology. So this is the muscle. This becomes Mr. Arnold Schwarzenegger, this muscle, which is muscularis mucosae, right? And then there is deposition of fat in the submucosa, and that is why you see it. So that also encroaches on the lumen. So what happens is, if you see this from this publication, this is old publication. If you see, this is the normal histology. So this is the muscularis mucosa. And in UC, chronic UC, it has become, yeah, Arnold Schwarzenegger. Who is the present generation? The young generation doesn't know his name. So who is the big man in the world right now? Who? You don't know? The boys? Okay. So, yeah. So this is it. And number two, if you see here, submucosa, look at this fat. Fat increases. So that increases. Now, because it has lost, it becomes contracted. So these muscles are contracted, and that's why it's a lead pipe, featureless. It becomes smaller. It becomes like this, right? Lead pipe appearance. And if you look carefully, let me show you. Here you are. This is, the rectum. Do you see this low density rim? So this is fat. This is submucosal fat. Actually, we pick it up and we say that this is a chronic, but we don't say it's UC. We say it is IBD, because the same thing happens in Crohn's also. And if you look carefully, look at this one. Do you see this fat? This one. So this is submucosal fat. UC or Crohn's? Why? Excellent. Skip lesions and deep ulcers. Excellent. So if you see the deep ulcers in profile, versus end on. Of course, that is end face view of ephthoid ulcers. But deep ulcers, there are deeper than ephthoid ulcer are rose thorn ulcers. Now, does it make sense? Rose thorn. Do you see this? For example, this one. It's so deep. It is going. And in UC, you will never see that, right? So skip lesions plus rose thorn ulcers. And then what about the ileum? Even the terminal ileum is involved. So this is classical exam film for Crohn's disease. And this is the same thing, more chronic. It is fibrosed, isn't it? And it is quiescent. You don't see anything very acute there. And it is absolutely fibrosed. So this is just tells you the spectrum and the clinical spectrum. This is diverticulitis. So of course, diverticulitis CT, I think, is the most common and important CT. I'm not going to concentrate too much on that because of time factor. But I think in UK, one of the most common conditions which we see with acute presentation is diverticulitis. And the spectrum is, if you ask me that, the spectrum in Crohn's disease, for example, is very unique because so many complications. Diverticulitis, I think, beats Crohn's in its presentations. Unbelievable. Because the patients will be sitting on this. There can be so many fistulas. And anything which can happen with Crohn also happens here. But the presentation will be more acute at times because they can present with fecal peritonitis and things like that. Crohn's people do not present with that kind of acute, hyperacute things. And the fistulas which can happen are everything, whatever in vesical fistula, then ileal fistula, then small bowel obstruction, then venous thrombosis, then cutaneous fistula, then vesical as in seminal vesical fistula, vaginal fistula, bladder fistula, everything can happen. So I'm intentionally not showing you many cases for because of time factor. One thing is know your pathology and make your radiology. Here is another Arnold Schwarzenegger in diverticulitis. What happens? That the muscle, this time the real muscle, the external, the muscularis mucosa, it becomes hypertrophied. It becomes hypertrophied. And it gives you a unique pattern in cases of this is a stricture, and this stricture is diverticular stricture, and there is no mucosal destruction. So at times we have got cases in this hospital where the clinicians, they ring me up, they say that it was too tight. The stricture was too tight. Why is that stricture? This is because of hypertrophy of the muscularis. So if you read your pathology, that is the mechanism in diverticulitis. It's not fibrosis or anything. So can you image it for us? And we can image. We have got a role there, and we can do in MR. And at times, I'm not saying that we are very good, but at times we can give you a reassurance. This is normal. And we look for this pattern of mucosal stricture with a normal mucosa. I'm not going to teach you, but this is normal mucosa. And this is a diverticulum, diverticulum, diverticulum. Now, this is a classical case of diverticulitis, which you people have to develop your eyes. First of all, look at the colon. You remember I showed you pseudomembranous colitis? Now you see how mucosal thickening looks like. This is mucosal thickening. Is there a difference? No, there is no difference, except that that was too much, and that was pancolitis. So take-home point is that all kinds of colitis will appear similar, right? The pattern and the magnitude is something else. But here, there will be a pathology sitting next to it. So this is, the mucosa, the two walls of the mucosa are sort of adherent to each other because of submucosal edema. Now with that, remember the pathophysiology. The diverticulum must perforate. The perforation can be microscopic or macroscopic. When it perforates, you will find fat stranding surrounding it. This is the key finding. This fat stranding can be with bubble of air or bubbles of air. They are within the mesentery. Usually, this is the sigmoid has got its own mesentery. So this is the sigmoid mesentery. Now, a surgeon can ask us that is, you know, or on the other hand, we can be over exuberant and tell the surgeon, call them, oh, please do a laparotomy, that kind of a thing. No, no, it doesn't work like this. These gas bubbles don't count it as pneumoperitoneum. They stay preservative management is there. Otherwise, if you see air all the way up below the diaphragm, then you call it. Means the perforation is real big. And if you see ascites, etc., then you say that this is problem. Because I'll tell you the surgical staging. Uh, if you see, this is another case of diverticulitis, where you can see what is this? Abscess sitting there. So this is the loop, and you can see this abscess, and there is an air fluid level, and there is you can see this diverticuli and abscess sitting there. So will you surgery or no surgery? What do you think? There is an abscess. IR, excellent. So this is the surgical staging, Hinchey classification. Key point is that if you are not in this world, stage 3, generalized purulent peritonitis or generalized fecal peritonitis, you don't open it. You don't open it. You just do conservative, right? So that was it. Yes, please. Classical exam case in which you have to stretch your imagination. What is happening here? Here, here. Artifact is there, very good thought. So there is an artifact. Now think what is happening. Around that artifact, there is something here. Foreign body is a very good thought. What else? Next. Say again. Not a drain insertion. So your thought process is good. Let me give you a hint. Our friends, the surgeons, were involved in this. This is a never event, another hit. Right? In Basildon, we scanned a case of an artery forceps inside. Can you imagine? Luckily, this was in overseas. The surgery was done overseas, but we have done an artery forceps. And I've got 3 cases of Gossi-Bomas in my teaching files. One of them on MR. Luckily, all the surgeries were overseas. And sometimes what the key point is that go back to the concepts. There is the swabs which is used in surgery. They have got a thread of barium. We call it barium impregnated thread. That is why if you X-ray them, you can see them. That is the concept, because they have got their own protocol. It's a never event in UK. I have not seen any UK patient in my practice here in 20 years. I've seen 4 or 5 overseas ones. The key one was the artery forceps, left hand side. Can you imagine the patient pass through the security every day? So, no, say again? No CT. That was a CT. So I've saved it. That case is now some of these. I've got one in rectum in post prostatic for about 35 years. It was correction for about 15 years. It was there. But one of our consultants, who is a stroke consultant, he wrote a case report on this in Croatia, sitting there for 35 years. So what have you learned? These Gossi-Bomas can present acutely, or they can be here historically because they become sort of, indolent. And the radiology is horrendous. Because radiologically speaking, of course, if the patient present with acute abscess, you will see enhancement, rim enhancement, the clinical will be there. Key point is the concept of barium impregnated cotton wool. Barium is a very high density material. If you do a CT with a barium, you will get artifacts. So why, you know why these artifacts are there? Because it's barium. So then your mind goes into this, that we call in radiology these kinds of cases a story case. And we ask them in our exam, story, what is the story? You tell me the story. The story is that because of this, this is a post-surgical. It was left there. So gossypiboma is cotton wool. Tumor is, this is some people call it a textiloma. Okay, so now I have already shown you a case of duodenal bleed, just showing you a case of acute large bowel bleed. Key points I have already taught you, which can be exam points, that when a patient comes to you with melena or hematemesis and you want to organize a CT, you will say, I want to do a CT angiogram. Non-enhanced phase is a must. And the non-enhanced phase, if you don't do non-enhanced phase, you are sitting, you are absolutely, because please remember that many things in the gut are high density, even tablets are high density, and you are going to miss it. So this is acute bleed. How can you confirm? This is a non-enhanced phase. And how do you pick up that this is an arterial phase? Look at the arteries, the common iliac arteries. Here, there is no contrast. So this is acute bleed of cecal. And similarly, this is a post-polypectomy case. I think this might interest both gastroenterology and the surgeons. And the patient presented with, if you see here, this thing. Now, yeah, good case for you to see the phases. Aorta, non-enhanced, look at the aorta. Arterial, how bright it is. And then venous, and it is less bright, right? Look at the veins so these are the hepatic veins. This is the IVC, this is hepatic veins, and on arterial, you don't see them very well, right? So the blood hasn't got, the contrast did not have time to go into that. But at this site, there was a polyp which was removed, and now there is active bleed. Confirm that there was nothing there, high density on the pre-contrast. And on the delayed or venous phase, you might see more of blush. So that is the role. Last thing for this session is rectal carcinoma. Now, rectal carcinoma, I know that gastroenterologists are not very interested, and the surgeons are totally interested. So actually, I received a lot of messages from surgeons. Can you teach? I said, I will keep a separate session for this. I will require a day to teach you rectal carcinoma staging and a workshop model. Maybe next year we can do that. Select cases which the gastroenterologist and the surgeon want, and we can do a workshop model, just a MR and CT. But it will be good for all of you to see the role of radiology. Radiology has got key role in rectal carcinoma. And the key role is that you diagnose, we stage. Remember, we don't diagnose. We don't diagnose. And at times, particularly overseas, I have seen people ask for rectal carcinoma, rule out a tumor. It is rubbish. We just send it back. You have to diagnose. You do a flexi or a whatever. You see it, you biopsy it, and then tell us where it is. You have to tell us that it is, let's say, 7 centimeters from the anal verge. You have to use that language. And this is it. Then comes our role. Then we will tell you what is happening. But if you don't tell us, we are going to overcall it. Our report is going to be rubbish. So this is a case which, how do we report? Let's go back to the anatomy. Please remember that. So it's a very concise rectal carcinoma thing, which I'm going to, I'll just take 10-15 minutes for this. Otherwise, it's a very longish subject. Just to give you an idea. Now, anatomy-wise, within the abdomen, there are three cavities. peritoneal cavity, retroperitoneal, and then there, or should I say, three spaces is the correct word actually. Retroperitoneal and then extraperitoneal pelvic spaces. Many people forget the concept of extraperitoneal pelvic spaces. These are, as the name tells you, that this is in the pelvis, and these are extraperitoneal. So it is not retroperitoneal, it is not peritoneal cavity. How many of you remember this from your MBBS? Anybody? Okay, let me ask you, how many of you know of this extraperitoneal pelvic spaces or have read about it in your MBBS? Very few. Oh, surgeons are always there. Surgeons are our friends. They have got good anatomy concepts, right? They see things. Have you remember this word? All of you must have read it. Have you ever thought about it? Bladder rupture, extraperitoneal bladder rupture versus intraperitoneal. I am sure you must have read about it. That bladder rupture can be intraperitoneal, bladder rupture can be extraperitoneal. No, very bad. Okay, so what happens is that this space is where we are concentrating. Now, if you see here, this is the uterus. This blue, light blue cavity is the peritoneal cavity. This rectum, this uterus, this bladder, this vagina, all of these are sitting in the extraperitoneal pelvic spaces. Now, if you go back to the basics, extraperitoneal pelvic spaces, urinary bladder is in the extraperitoneal pelvic space, distal ureter, body of uterus, vagina, rectum. Now, this is important for you to remember. Rectum, the upper and middle rectum is in the retroperitoneum, and portion of peritoneum also touches it. Distal is extra peritoneal. Now, two spaces which I will highlight to you: perirectal space, pre-sacral space. So just concentrate. So forget about the concepts, just concentrate on the take-home points. This is the rectum. Around the rectum, there is a fascia. This fascia is known as mesorectal fascia. And around the rectum, there is fat. This is known as perirectal space, or perirectal fat is the portion of it. If a rectal tumor, if from here goes into the fat, right? It has gone through the muscularis into the fat. That is one scenario. Second scenario. Second scenario is it goes and invades or touches the mesorectal fascia is another scenario, right? And it's a black and white scenario. It completely changes the management of the patient. And our main role is to tell them. Now, if you see here on an MR, this is the rectum, this is the mesorectal fascia, and this is the fat. Now, another point to remember is that there is a concept of peritoneal reflection. If I go back to this diagram, and even here you can see that this blue cavity is the peritoneum. So the peritoneum is adherent here to the anterior wall of the rectum. Which part of the rectum? The upper rectum. The lower rectum is totally, there is no no peritoneal cavity anterior to this. So if you go back here, in this case, this is a male, this is a female. And in this male, these are the prostate, this is the seminal vesicle. This thing is the peritoneal reflection, and it is adherent here. In a female, this is the uterus, and this is the peritoneal reflection. A tumor which is sitting here and goes out of the wall will be invading what? The peritoneal cavity. The staging changes, right? So the surgeons will ask us, is it beyond we use the word reflection. Is it proximal or distal? But coming back, I'll show you MR of the rectum. Before I show you an MR of the rectum, I think I had to show you this thing, which I forgot. Now, we are going to trace, this is a case of pancolitis. Pancolitis. And our role is something happening in the, this is a CT. So we are in the rectum, in the sigmoid. Do you think this is normal? Mucosal thickening. And where my mouse is, let's trace it. It goes, now this is a very good example of, uh, you know, large bowel, which is difficult to trace because the region which I was tracing was actually a redundant type of cecum. If you see here, this is the sigmoid colon. It goes here, still normal or abnormal? So the sigmoid is abnormal. The now I'm in the descending colon. Normal or abnormal? Abnormal. Now I'm heading to the splenic flexure. Normal or abnormal? I am heading to the transverse colon. What do you think? Abnormal. So we are heading towards the hepatic flexure. Normal, abnormal. And then we are going into the descending colon and correction, ascending colon. Thank you. And do you see this cecum is sitting in the pelvis? So it is so redundant. Having said that, what do you think is happening? Now, interestingly, this is the cecum and this is maybe the ileocecal junction. So this is a very abnormal cecum, but that is embryology. So is it a case of pancolitis? What is your differential? Right. So what is the most common cause of pancolitis? You see. So if you see here, I am going to show you the coronal, and this is the sigmoid. This is the sigmoid. This is the descending, and then this is the transverse and the hepatic flexure, and of course, uh, this is the ascending. This cecum is very, look at the position of this cecum. So this is, my aim was to show you a normal MR of the rectum. So what we will do is that quickly put a sagittal here and then put, I think this one. Yeah. So if you see here, this is, when they use the word anal verge, 7 centimeters, so we start measuring from here. We, put a cursor here, put a cursor here, and then you see it. So this is on a sagittal. You can see that this is the prostate and this is the seminal vesicle. What do you think is happening here? What is this? Peritoneal reflection. Here you are. Do you see this? This is attached. You can imagine that this part of rectum, which is anterior to this part, is peritoneal cavity. So if a tumor was sitting here and it breaches the muscularis, it goes into the peritoneal cavity. Game changer, T4, right? On the other hand, if a tumor is sitting here, it goes anterior, there is no peritoneum there, right? What is there? What is there is better seen on this axial, where you can see this. So this is the mesorectal fascia. This fascia contains the mesorectal fat. So, and you can see these seminal vesicles here. Key thing for us is that if the tumor goes out, does it touch the mesorectal fat or not? So I will go back to the PowerPoint. Now, the key concept is this one on this diagram, total mesorectal excision. Total mesorectal, if you see this diagram, what they do is that they remove the tumor as well as all of this fascia, right? With it is the fat. This is known as TME in surgery. And TME has reduced local recurrence from 40% to 11%. So they want us to, if a tumor is going and touching the mesorectal fascia, means I'm using a histology term that circumferential resection margin is positive because they will remove it and till the edge the tumor is coming. You don't know if it has gone beyond, right? So what you do is that if your report is uh, when it goes into, so this is the classification. This is the T3 tumor, which goes into the mesorectal fat. Is it touching the mesorectal fascia? If it is touching the mesorectal fascia, the treatment is changed. What is the treatment? They will give 6 months new adjuvant chemo radios and then do the scan. They want to reduce it and then do correction, then do surgery. Then do surgery. Of course, they might do a rescan. This is the rectal carcinoma protocol. Usually, we concentrate on T2 weighted sequences. There is some role of DWI, and this is so this is one tumor. If you see this tumor, there is a lymph node here. Is this tumor going to the mesorectal fascia? No. So I will report it that this is a circumferential resection margin negative, right? Now, this is how we measure. We measure like this. This is from the anal verge, 4.9 centimeter, 4.6, 4 point this. So in our reports, we have to give these answers. What is the distance from the anal verge? By the way, they would have given it to us, but we will sort of confirm. And sometimes there will be a bit of discrepancy. What is the craniocaudal dimension? There is a tumor at 7 centimeter from the anal verge. Craniocaudal dimension is this much. Extension into the mesorectal fat, yes or no. Then distance from the circumferential resection margin, is it positive or negative? And I am not going into details of what is the criteria. And then we look for any venous invasion. I'll show you a case in which we call it extramural venous invasion. And the prognosis goes down. Are there any pelvic organs involved? Are there any lymph nodes involved? So this is what we have to answer. So good that this is the last case and then we stop here because so I'm just going to show you an MR and then we stop. We are in time, should I say? Now, if you see here, I'm showing you a rectal carcinoma T3. So I am going to put a sagittal here. Yeah. So look here. Now, here you can see this tumor here. So I'll measure that from here to here, how much is the distance, then what is the craniocaudal. Anteriorly, if you see here, you can see this mesorectal fascia, right? It is much below the peritoneal reflection. So let's go to the axial. Now on axial, I am down here. I am at the level of prostate. As I'm coming superiorly, this is still the prostate uh, here. So the tumor comes into view. Tumor is breaching here, where you can see these whiskers. It is breaching. Frank breach here. Agreed? It is going into the mesorectal fat. This is the fascia. What do you think is happening here? So it is going and touching. If it is touching or if it is within 1 millimeter of it, we call it that this is circumferential resection margin positive. How will it affect the treatment? 6 months new adjuvant chemo and radio. So we tell them in the MDT that this is it. And then on our report, the imaging is done. In this case, sorry, in this, our report actually changes the management. And this is a vein here. I don't want to overload you, but this is dilated, and this is what we call extramural venous invasion. So thank you very much. 5 minute break. I can I can see the course is dying down. You need something. Do some some pep, what we call cheerleading or something. Coming next is liver, isn't it? Next is liver. So double dose liver. नहीं यार बस अभी इसको इसको ना एक सेकंड, इसको मैं स्क्रीन को शेयर करना था। is left is liver, then the biliary system, and then the pancreas. And it is the most important for your exam, particularly gastroenterology, your European exam, and etc. But it is a bit too much to cover. I have selected in gastro, particularly focal hepatic lesions. And I'll give you a bit of concepts. I want to also you to learn day to day how do you utilize radiology, etc. So it's going to be a bit practical. But the biliary system, I have put in a lot of slides, but they will be rapid fire. I'll ask you, what is this? And you will tell me this is, it will be simple, but the slides will be a bit too much. And now you have to really motivate yourself. Okay? That be. And pancreas, I tell you, pancreas is very, very, very important. It is so important, solid tumor, cystic tumor. In cystic tumor, this is IPMN, this is mucinous cyst, this is serous cyst. Classical exam. Hard luck. That will be the last day of the last session of the day. So it's going to be quite a bit. So I warn you, you are in a high altitude death zone now. Okay. So incidental focal hepatic lesion. I think I've only covered incidental, but within this, there is a world. On the other hand, I think I put in a MR of, I just want to teach you that how do you scan a case of iron overload, hemochromatosis, which is a liver MR. But that is just 1 minute. Now, if you see, concentrate here on the anatomy. Anatomy that liver is a unique organ which has got double blood supply. Artery is coming in and the portal vein is coming. Portal vein brings blood from the gut. These three things are brothers and sisters. They always travel together. Portal vein, the hepatic artery and or its branch, and the biliary system. They ultimately go into the liver and they go into a sinusoid where, and from the sinusoid, a central vein arises. This central vein drains into the hepatic veins and ultimately into the IVC. This is the central lobule. And, this is what we call the portal triad, where the brothers and sisters are together, which is the portal vein, hepatic artery, and the bile duct. And this is the central vein, and from there originates the hepatic system. I particularly want you to concentrate here that this is the central vein, and along this, so this is the portal, the portal triad, and it ultimately ends up into this central lane. These cells are hepatocytes. What do hepatocytes do? Answer? Bile. Exactly. So bile, right? And there are Kupffer cells also, which is different. So this green thing is the bile, right? And now in imaging, please remember this concept, because this is key exam concept, that we have got imaging where we can image normal hepatocyte. So we have got a particular type of MR scan contrast agent, which has got a particular type of phase in which normal hepatocytes behave differently and abnormal hepatocytes do not enhance. So if there is a tumor will not have hepatocytes. And keeping this, we can diagnose so many things. And for you, that is critical to learn. CT, liver and biliary system. Now our good old CT. So this is now our area of interest is the liver. On axial slice, we are in the lungs. Now, as we come down, we have got the liver. Now, one vessel, this is the IVC. This is the IVC, which is just heading into the right atrium here. So this IVC, if you see, vessels are draining into the IVC. Which vessels are these? These are the hepatic veins. These are the hepatic veins. And as we go more inferiorly, now in the midline, you have got this vessel. What is this vessel? This is the portal vein. And then as we trace it, we go out. So first of all, let's review the vascular anatomy once again. Now, this is the splenic vein. So it is coming from the spleen. It I'm pointing out at the artery. No, I was correctly. Yes. This is the splenic vein. It comes here and it goes here, and this is the confluence with the superior mesenteric vein. This is the superior mesenteric vein. So from here onwards is the portal vein. This is the extrahepatic portal vein. Please remember your anatomy. There is a strict structure here, linear, which you can stretch of imagination, you can see it. What is this? Bile duct. And this is what we see on ultrasound. You just put a probe there, and this is a double barrel type of a thing. The inferior thing is the portal vein, superior is the CBD. And this is what we do on ultrasound. And if it is dilated, we see it very well. Now, this is the portal vein. It goes in. This is the porta hepatis. And then the left hepatic vein, left portal vein and the right. And you can see that it gives branches, etc. Intentionally, I have not taught you. I put the slides there, and then I thought it will take me another 20 minutes just to teach you the segmental anatomy of liver, which the surgeons love because they have to do, just to give you just briefly, that liver is divided into 8 segments, and they are in Roman letters, segment 1, 2, 3, 4, 5, 6, 7, 8. And each segment is physiologically speaking a different entity because it is supplied by a segmental artery and a segmental vein and segmental biliary system. When we want to do surgery, the classical thing for a surgeon is colon cancer. Colon cancer with metastasis in the liver is very interesting. It is one example where usually when there is liver metastasis, you don't do any surgeries. But in colon cancer, the results are very good even if you remove the metastasis. So they want to know the segment, which segment is involved. And when they do surgery, they remove that segment. It's a sort of a functional unit. Now, we also in our reports and in your upper GI MDT, you actually we reported like this, that there is a hemangioma, right? So I put the slides, but I put it after thank you because I thought I will not be able to cover it. It's too ambitious to teach. And this is what I was saying. It's too difficult to teach everything. But you people should know that concept. Actually, in the MDT, you ask us, which segment, because you want to document it. It's a very good idea that we are speaking the same language. That is segment 2, right? It is segment 3. It is at the junction of segment 2 and 3. Now, and please remember that we use the vascular planes and some other planes to divide the liver. So leave it to a side. Now, with that, you have got this fissure another fissure here. This one is another fissure. So this lobe, generally speaking, is the left lobe, and this one is the right lobe, and this is the caudate lobe. Caudate lobe enlarges in cirrhosis, right? So this is the caudate lobe, and it is also known as the segment 1. So this is liver. As we go, so we are going down here, and here the liver finishes. Maybe I should tell you that in the right lobe, the posterior segments are easy to remember. The posterior segment are 7 and 6. Key point to remember. Something which touches the kidney is segment 6. At least you remember one segment today. So this is segment 6. And as I go superiorly, this is segment 7. You know, this is posterior, right? And so I think enough of the segments. Now, let me go to corona. Coronal is very good for biliary system, and you must see the coronal for biliary system. So this is the left lobe, this is the gallbladder, and here you are. Sorry, I should have shown you the biliary system on axial. Now here, this is the pancreas. How do I see the CBD on an axial? Here it is just a stretch of imagination. As I am going superiorly, do you see this? There is something here. Do you see this thing? This is, so try to trace it because it is so small. We are struggling. But then I go to a coronal, and on coronal you can, you see this thing? So you don't see it because in this particular case it is maybe 1 or 2 millimeter type of a thing. So which is a good sign for you, right? That this is it, and this is the CBD. Okay, now let's go to I really want you to concentrate. This is going to be rewarding and difficult. Uh, so focal hepatic lesions is a big subject in radiology, and there is a subchapter of this incidental focal hepatic lesions. For example, if there is a patient with cirrhosis, a focal hepatic lesion, you should be worried about regenerating nodule versus dysplastic nodule versus HCC, right? And if a patient is known case of cancer, you should be worried about metastasis. But incidental focal hepatic lesions are lesions which are picked up incidentally without you just scan the liver and you pick up incidentally. It is such a big number. On autopsy it is up to 20%. It is up to 20%. And cysts are very common, and what happens is that cyst itself, you know, which is better, ultrasound versus CT for a cyst? Ultrasound. So when I'm reporting a CT and I picked up a esophageal carcinoma and I see a cyst, I have to be very confident to say that this is a cyst and not a metastasis or a cystic metastasis. So many a times it all depends where you are working and what kinds of facilities are there. Our index of doing an threshold of doing an MR is quite low, but because we have got the facility, there will be other places where you will not have the facility. So we use it, but at times you can ask for an ultrasound. Now, hemangiomas, 5 to 20% focal nodular hyperplasia is something very important for your exam. Please remember, focal nodular hyperplasia is not a neoplasia. It is not a neoplasia. What is happening is that there is a arteriovenous malformation type of a thing, and it enhances. The problem is it enhances on arterial phase. And when it enhances on arterial phase, it can be good, it can be bad. Now in imaging, we have reached a point where we have got imaging criterias or facilities to, 100%. 100%. We are better than biopsy, right? Radiology. Yeah, good. Yeah. So then, but here, if you see here, there is a tumor known as adenoma. Adenoma also enhances on arterial phase. It is benign, but 10% of adenomas can convert to malignancy. And adenomas can also present with bleeding. So they are not as benign as focal nodular hyperplasia. So can we differentiate between the two? Yes is the answer. and it's a game changer. We started this service, I think 2008 or 9, we started hepatobiliary contrast. We started MR liver in this hospital. There was no MR liver. And now I say, where were we? And we were in dark ages. And it has created a lot of workload also. Pancreas. Where was, when I'm here since 20 years and there was no MRCP. And now every single case we pick up an IPMN, and then you people put it in an MDT. I don't know how much drain it is. And 20 years ago, there was no IPMN in this world. So interestingly, we are a victim of our own success also in radiology. So because we have become so big, dependable that people are dependent on us. So good. So become a radiologist, you will never be out of job. So any takers? Yes. Oh, I can see a few hands. Conversions. Now, if you see pseudo lesions, focal fatty spared area, focal fatty area, focal perfusion abnormality. Now, this is big. You know what will happen? You cirrhotic lesion, and there is a perfusion, it enhances on arterial phase. You are worried, is it a HCC? What is the criteria of HCC? HCC will enhance on arterial. Then you have got a second phase. On second phase, it will show washout, and this one will not. How sensitive is CT for that? And now we realize that CT is not all that sensitive, and MR is up there. So these are the type of things. Focal fatty infiltration, it will be hypodense as compared, and this is a case of breast cancer. And you will report it on the CT, you will say, oh, what is this? And I cannot rule out metastasis. Is it helpful for you? You are the clinician. I will have to report it like this. Now, luckily, we have got the imaging tools to solve this. So I really love liver imaging because we have reached a point within the last 20, we are up there. Remember, histopathology. So, and we have got molecular basis of this imaging. Malignant lesions like metastasis, HCC, intrahepatic cholangiocarcinoma, and we can differentiate between the two. This is a key slide. Take a picture. What is the concept? What is the concept of what we call characterizing a focal lesion? Enhancement pattern. This is what I'm going to teach you, and this is what they are going to give you cases in the exam. Enhancement pattern. So various lesions have got various kinds of enhancement pattern, and sometimes the background, of pathology makes it simple. Gross pathological features, for example, if a patient has blood calcification, fat, fibrosis, etc., this helps. Clinical history is helpful, particularly in HCC. You see, my index of suspicion for an arterially enhancing case in a cirrhosis will be totally different than a normal case. FNH is incidental finding in young. Hepatic adenomas are very important. Those of you who are into anabolic steroids, gym, uh, or ladies with oral contraceptives, or of course glycogen storage disease. So these are the things in which hepatic adenoma is something which has to. Key slide once again. These are the things which we have got in our armory. In our armory, what is there? Ultrasound, of course, you can do Doppler. We have got contrast ultrasound. We call it CEUS, contrast enhanced ultrasound. In our hospital, we are a DGH, but we have got a service. We started it, I think, in 2010 or something. So it's a very useful tool. Key point. You can do it in renal failure. So the patient cannot have, let's say, CT because of renal failure, and the patient has got a pacemaker, or NSF is another, issue, because if a patient has got EGFR less than 15, they can potentially get a disease by the name of NSF, nephrogenic systemic fibrosis. 400 people in the world have died of this disease. And if you read about it, it's very interesting how did they diagnose. Because what happens is that gadolinium goes into if the renal failure is of that magnitude, it goes into particular parts of body and it's a fatal disease, potentially fatal disease. Viscera is involved, fibrosis. So, but there are particular types of gadolinium or contrast agent which are more prone to develop it. In our hospital, we have got an NSF protocol. Look at that word, and you should know it. That if the EGFR is less than X, previously we used to say 30 EGFR. Now 15 EGFR. You are a gastroenterologist, you say the patient cannot have CT, I want MR. I say, what is the EGFR? EGFR is 16. Okay, put up a NSF performer. What is NSF? So what is NSF is that you have to fill up this performer. The patient has to consent, risk versus benefit type of a thing. Theoretically speaking, there is less to negligible risk of NSF with the new contrast agents, etc. But you have to write it down. You take the responsibility. We will not do it. Now, here comes contrast ultrasound. You can ask for contrast ultrasound. No NSF, no, this, and the sensitivity specificity is very good. In contrast ultrasound, it's a very good tool to have to fill up the gaps. And many a times it gives a black and white answer. Many a times, of course, just like other modalities, we sit on the fence, but it is, it's a very good tool in the armory of focal hepatic lesions. We have got it luckily. CT, now this concept is again asked in your exam, surgeons and your gastroenterologists, both. Usually, when you do a scan, you just do a single scan, isn't it? Portal venous face. A usual abdomen is portal venous face. It might be chest, abdomen, and pelvis, and we are scanning in the portal venous face. When you pick up a focal hepatic lesion, can you characterize a lesion? Yes, sometimes, but many a times you do not. If it is a frank metastasis, you don't need anything else. But in many of these cases, you have to recall the patient to do we call it triple phase, non-enhanced arterial venous. And previously, before the era of MR, we used to do delayed phase also. We used to call it equilibrium phase. I remember when I joined radiology, in the first book which I read, they said that for hemangioma, you can scan patient periodically for 35 minutes. So, wow, 35 minutes, radiation, you are roasting the patient. So now we have got MR. Now, then we have got MR. So this concept I will tell you. In MR, we have got two kinds of contrast agent. One is normal gadolinium, and the second one is hepatobiliary specific. HSA is just as a short form. Hepatobiliary specific contrast agent is a specific contrast agent which we have. The price of a HSA, one vial is 118 pounds versus 17 pounds for the other one. So you cannot use it just like that. But we have got enough so we actually protocol, we say that we want this. And the key point to remember is histology. I told you the histology, hepatocytes. This has got a special phase. We call it 20-minute delay phase, which I'll show you. In 20 minutes, it is excreted via the hepatocytes. So there are normal hepatocytes, you will see enhancement. If there are no hepatocytes, you've got the answer. So you can utilize it. Now I'm giving you a take-home point, but I'll give you the example later on. Take-home point. What is the take-home point? FNH. FNH will enhance on arterial phase, right? And it will not show washout on other phases. But because there are normal hepatocyte, it will still retain contrast on the delayed phase. If it is an adenoma, it will not. So this is how you differentiate. Similarly, you can utilize the same principle. Will metastasis have normal hepatocytes? No. HCC, will it have? No. So now it is creeping in even the guidelines. Classical HCC guidelines, it is now regarded as an ancillary They have not put it in the guidelines for the simple reason that every facility hasn't got this. So they don't want to put it as a guideline. But we, for HCC, our classical HCC criteria is arterial enhancement and then washout. It becomes black. Ancillary criteria is additional criteria. So they've put it there that ancillary, that on a hepatocyte specific, it will be black. It will not enhance. So I'll show you. And of course, then biopsy. Because of where we are, the biopsy rate has gone down because many cases we diagnose on this, and if we are doubt, we just say let's do a follow up, things like that. And some of the cases are being followed up since years, but at least we know that they are, even if we have not given a black and white diagnosis, we know it's not malignant. So we have done our duty. So please remember, and this is for the young doctors, that it all depends on where you are working. These are the factors: availability of a tissue, modality. What is the capacity? Can we do it? You know, we have got 4 scanners, so we can do a lot of liver MR. If another hospital has got a single, they will not do liver MRs. Liver MR can cost you 50 minutes. I can do 2.5 TIA brain scans in that, right? So I will not do it. Not 2.5, I can do three TIA scans. Much more important, isn't it? So it all depends where you are working. And for juniors, it is important for you to remember that when you are working in Broomfield, you might have something, and in Basildon, you might not have something. These are the factors where you are working. In our hospital, we have got everything as far as liver is concerned. Local practice, cost, radiation risk, contrast, sensitivity, invasive versus non-invasive. So CT advantage, disadvantage, you know, it is cost, nephrotoxicity, MR, risk of NSF, I have told you. Claustrophobia is quite a problem. 14% of people have got claustrophobia. And some of them can never tolerate an MR. And we have to respect that. We don't judge them on that. Even many of you will have claustrophobia. Have an MR and then you will know. So the point is that, uh, uh, and then they move. They are in the age and they just move. And I cannot make a diagnosis. The arterial phase is destroyed. What should we do? Let's do a contrast ultrasound. So this is what we do. Contrast ultrasound. Next 3 slides are about contrast ultrasound. No radiation, no side effects of contrast, including nephrotoxicity. This is the big one, and less cost. Sensitivity, specificity either equal or better. This is how a contrast ultrasound works. We have got an agent. There is a absolute monopoly of this agent known as SonoView, made by Bracco in Italy. This is actually bubble ultrasound. It is made up of micro bubbles. The physics is unbelievable, very interesting physics. You use a contrast ultrasound, dependent ultrasound machine, and you get these kinds of images. And this is how a bubble is formed. It has got a shell, it has got a lumen, it has got a molecular, this is the structure. This bubble is as big as an RBC. This stays in the vessel, unlike other contrast agent. For liver, it is very good, and because it gives a particular phase. Now, these are the 3 phases which we can see on contrast ultrasound: arterial phase, venous phase, and a late phase, which is 3 to 5 centimeter. Look at this lesion: arterial phase enhancement, a bit of washout, complete washout. Good or bad? What do you think? Bad. So this is what we call bad. Black is bad. Black is bad sign. Now, contrast ultrasound, nice guidelines in 2012. These are big. If you pick up an incidental focal hepatic lesion on ultrasound as the first next test, do a contrast ultrasound. These are nice guidelines. And of course, if metastasis or HCC are not picked up on other modality, we can do it. Now concentrate on this one. These are the phases. Now this is a CT scan, and this is, just look at the liver, look at the aorta. And you can see that there is a bit of contrast in the veins, and even aorta is enhancing. So this is a classical portal venous phase. Look at these phases. This is a non-enhanced phase. This is an arterial phase. Now look here. Aorta is very, very bright. These are the hepatic arteries. There is a lesion which is enhancing, but the veins are not visible. Compare it with this, or compare it with this. And on venous phase, you can see the veins and the parenchyma. So we can also do delayed phase than this. It will become a 4 stages, right? But these days we don't need it, but we used to do it. On MR, same principle: arterial, venous, and equilibrium. Now we have got the luxury in MR that we can do delayed phases, and we utilize it. We do scanning till 10 minutes. We call it the equilibrium phase. Take a picture of this. This is an exam question. Equilibrium phase. In equilibrium phase, you remember these contrast agents are extra, so they permeate outside the vessels and they go into the interstitium. Equilibrium phase means where equal concentration is in the interstitium and in the vessel. That is this phase. Now the principle again very important for your exam of uh, is it benign versus malignant. This is an arterially phased lesion which is enhancing. Venous phase, no washout. Equilibrium phase, no washout. What does it mean? The word washout means compare it with the surrounding parenchyma of liver. Do not compare lesion itself from arterial to venous. Compare it with the surrounding parenchyma. So this is benign. No washout means good. Malignant. You see this? Arterial phase enhancement, maybe a bit of washout in equilibrium, it has become black, right? So this is bad. Black is bad. Pitfalls. There are pitfalls. The pitfalls is adenomas might not behave like this. And there are particular types of HCC, cholangiocarcinoma. These we know these pitfalls, and we know how to tackle that. This is a contrast ultrasound where you have got a in late phase a black lesion here, which is not a cyst, so it has to be. This is black is bad sign. Look at this liver metastasis. Some enhancement, washout, washout. So this is bad. Of course, one can argue that if I scan it, I will say that this is an arterially enhancing lesion with washout. It is malignant characteristics. What can it be? The differential will be a HCC metastasis. Metastasis, I'll keep it as number one if there is no cirrhosis. If there is cirrhosis, I'll keep HCC as number one, right? So this one is a HCC where you can see this enhancement, and then this is in late phase, there is wash out. Now, uh, I told you that there are two types of lesion, extracellular and HSA, which is hepatocyte specific, which is excreted by the hepatocytes. So the one which we use, this agent which we use in Europe and UK is this one. This is the chemical name, and this is the trade name. In what I've seen is because it's a monopoly, everybody, even gastroenterologists, use this word. I want a Premovist scan, though it's not good practice because you're using a trade name, but it's a monopoly. So you use and just like in contrast ultrasound, there is a monopoly. SonoView, only one in the world. So here, this is in USA, there is another one, but that is not as good as this one, Premovist. So please remember that it is excreted by the liver, by the hepatocytes, and that is why we are able to pick it up. Concentrate on this one. Take a picture and take a picture of the next slide also when it is coming. This is the protocol of liver imaging. I love it. You know, this MR is with this
Recording
and
in
this with this,
progress.
and your thought process that this will be this and this will be that, and most of the time you get a good answer. And even if you are not sure, you get a, this is most likely benign, let's do a 3 month follow-up, right? So if you see, we do T2 weighted sequences. Now, this T1 weighted sequence, in phase and opposed phase, you must remember this concept. In phased and opposed phase are T1 weighted sequence. I'll show you the bigger versions, but these are done for fatty infiltration. These are very sensitive to pick up fat inside. I'll show you a scan. Then this is our favorite phase, which is diffusion weighted scan, and in which malignant lesions usually show restricted diffuse. They are bright on DWL. And benign lesions, so pitfall, hemangioma is a benign lesion but will show restricted diffusion. Now, then we do fat saturated pre-contrast T1. We use a arterial injector, auto injector. And then we do an arterial phase. We do a venous phase. And then 3 minute delay, 5 minute delay, 10 minute delay, right? So this is these things you cannot do on a CT. You can do, but you will give too much radiation. So in hepatos, take a picture once again. Hepatocyte specific contrast agent. The only difference is that you add a 20-minute delay. In 20 minutes, the hepatocytes excrete the contrast, and you want to catch that. So take a picture once again, very important for your exam. Benign versus malignant. And in our exams, this is what we ask. We are always very interested in arterially enhancing lesions. Arterially enhancing lesions. So they look very catchy. Wow, something is enhancing. Now, is it benign or malignant? So we will see washout. If the washout is not there, we will call it benign. If there is washout, we call it malignant. So FNH, adenoma, hemangioma, ash hemangioma, these are small in size, they can be benign. A malignant lesion include HCC, hypervascular metastasis. In radiology, we ask this question also. I don't know if it is relevant, that which metastases are usually, but the list is more than that. And then cholangiocarcinoma, we call it mass forming cholangiocarcinoma. Look here, 32-year-old fail, what is your differential? This is non-enhanced, arterial, portal venous. Arterial enhancing, no washout. What is your differential? So give me your differential. Very good. It is benign differential. So adenoma, what about FNH? So the point is that your answer also a time to think. Adenoma, you don't sit on adenomas like this. 10% of adenomas can become malignant. They can also grow. You can present with bleed in the A&E. And many people actually propagate that if possible, get rid of it. Otherwise, for the rest of your life, you're sitting on something, right? By the way, there is a concept that if you remove the patient from oral contraceptives or the bodybuilders from anabolic steroids, it regresses also. But adenoma is not something on which you can simply forget about it. FNH, end of story. So what will you do? So what you will do is do a FNH, MR with Primovist. And if you see here, arterial phase enhancement, no washout on venous phase, no washout on 3 minute, no washout on 5 minute, no washout on 10 minute. Till now, it can still be an adenoma or FNH, right? So if you have done this MR without Primovist, and this is what happens, many a times we have to recall another MR. You can not differentiate between them, but you do recall and do FNH. In this case, we have done Primovist, and it is enhancing, as still retaining contrast. What does it tell you? Normal hepatocytes. So it is an FNH. Black and white, 100% specificity, right? So it's a big position, which so this is FNH also have got scars. Uh, some of you were telling me that their exam in, clinical exam, they ask you which tumors are with scars and etc. FNH has got scar, but I don't have time to teach you. But many other tumors have got scars. But this is the hepatobiliary phase where it does not enhance. Uh, Specificity 96 to 100% is unbelievable, isn't it? Now, this is an adenoma. In this particular case, 22-year-old, this is from literature, it is not my case, where we see that arterial phase enhancement and venous, and then hepatobiliary, it becomes dark, right? There is a central scar. So adenomas can also have scar. And this is an adenoma. This is very interesting. Again, from literature, patient presented with CA breast. So on ultrasound, they said it is metastasis. On CT, they said it is metastasis, arterial enhancing, bad news. And on this one, you see arterial phase enhancement, no washout, and this is key, hepatobiliary phase. These are multiple FNH. So we have seen quite a few of them. And I've seen cases in which there are multiple FNH, multiple hemangiomas. And I have also seen cases in which multiple FNH and multiple adenoma. And you can discriminate. So look at this case. 49-year, oh, this is 2009 scan. And this is when we started our service in this hospital. And so fatty liver, with that, there is a focal lesion. The patient had mastectomy, breast surgery, and it was labeled as metastasis on ultrasound. So once it was labeled at metastasis, you know what? Anxious patient, anxious clinicians in 7 months had one ultrasound, three CTs, two biopsies, four MRIs. They were running after metastasis, right? And then in 2009, we started this service. And on the first this, this is the hepatobiliary phase. Well, it is FNH stop. End of story. So this is the take home point. Uh, so if you see, this is the arterial phase. No washout, no washout, no washout, no washout. On 20-minute phase, still contrast is retained. On a CT, if you see retrospectively, why it was called the way it is because of confidence, right? But you don't see any washout per se, but the point is that CT is not very sensitive, right? You remember I showed you a metastasis earlier in carcinoid metastasis. So I think the way it was reported, and this is unbelievable. And so who is better, biopsy versus radiology? So this is an exophytic lesion on ultrasound, and this one is adenoma, uh, arterial enhancement, no washout, no washout, washout, right? So HSA, I have already told you that you can use Primovist in difficult cases of uh, focal nodules in cirrhosis. It's a huge subject in radiology. Lyrides, I can teach you in 3 hours. Lyrides, which is focal lesions in cirrhosis. It's a nightmare scenario, but we are now very good, and our confidence level is different. It is taken as an ancillary lesion, ancillary criteria, hepatobiliary specific. If you see here, this is an arterial phase, and this is the venous phase. This is first scan, and we picked up on that there is something bad here. This is 20-minute. On follow-up, in 7 months down the road, you can see it has become larger. So it was confirmed to be HCC later on. What I'm trying to tell you, that 1.1 centimeter nodule was raised the issue that this is, but they sat on it for the time being because of clinical. And then, of course, it was confirmed, right? So uh, metastasis, now the surgeons utilize HSA, the Primovist, routinely for metastasis in what? Colon cancer metastasis, because they want to make sure that they don't miss any metastasis. So DWI sequence, I have told you it is very good. Restricted diffusion can be seen by many malignant lesions, but false positive is hemangioma. This is cirrhosis of liver. You can see T2 high signal, DWI restricted diffusion, arterial enhancement, and then washout. So this is classical HCC, and features of cirrhosis are there. You remember your good old, what is the segment which touches here? 6. Usually 6 goes here, isn't it? So it is what? Atrophic. Cirrhosis causes atrophy of segment 6 and 7, right? And hypertrophy of this, which is the caudate, which is the segment 1. And it also causes hypertrophy of segment 2 and 3, the left lobe. Now you can agree that the left lobe is more prominent as compared to this, particularly the segments which I have pointed out. Okay, this is intrahepatic cholangiocarcinoma. Intrahepatic cholangiocarcinoma. And know your pathology, make your radiology. So in cholangiocarcinoma, what is the pathology? We are talking about mass forming cholangiocarcinomas. Cholangiocarcinomas can be these types. Mass forming is intrahepatic cholangiocarcinoma, periductal, and intraductal growth. So this can be peripheral also. It can go anywhere. I'll show you in the biliary, cholangiocarcinoma of the biliary duct. We are talking about mass forming cholangiocarcinoma. What is the pathology? The pathology is that the lesion has got a lot of fibrosis. And when you give contrast, what happens is that the fibrosis enhances in a delayed form, right? So if you see here, this is arterial, this is venous, this is 3 minute, this is 5 minute, and this is 10 minute. Just compare this with this. Do you see that how there is centripetal extension of contrast? Please remember the differential for this is hemangioma. But I'm not teaching you in great detail here, but we have got a lot of parameters that what kind of enhancement in early phases you have hemangioma. You can confuse hemangiomas with intrahepatic cholangiocarcinomas, but with the features which we have, we can actually discriminate between the two. But so the fibrosis shows delayed enhancement. Fatty infiltration. Now, if you see this, previous surgery for rectal carcinoma, hypodensity, particularly here, is it metastasis or not? And you see this hypodensity? Yeah. Now, do a MR. Just concentrate on these sequences. First of all, if I show you the post-contrast sequence, you see even here, hypointensity is there. You're not very sure what is happening. Look at the in phase and a post phase. They come in pairs. In this, the image contains the signal of fat as well as water. Here, the fat is minused and fat becomes black to your eye. Now, first of all, you have to see the liver. You will agree that whole of the liver becomes black. So there is diffuse fatty infiltration. Over that, what is happening? In this region, it is even blacker, right? So the magnitude of focal fatty infiltration is even more. This is in the territory of pseudomass. So please remember these words: focal fatty infiltration versus fat spared area. So there is diffuse infiltration, and in which there is an area which hasn't got fat. On ultrasound, the report will come, oh, there is a focal lesion. So you have to then diagnose it. So this is another example. This is for surgeons particularly important, for gastroenterologists maybe, and we receive so many requests. where you do a surgery, cholecystectomy, or there is a case of trauma and the patient develops some ascites or things like that. Classical teaching is put in a needle and see the fluid. If the fluid has got bile salts, you've got your diagnosis. There is a biliary leak. Key point to remember, a blunder in your exam is there a low role of MRCP? Yes or no? How many of you think there is a role of MRCP? Biliary leak. No role. Who was that? Oh, surgeon. Oh my God. My friend. So, so there is absolutely no role of, well done. So why? On MRCP, what happens is that uh, you have to diagnose that contrast is going from the biliary system outside the biliary system. How can you diagnose? Something which is outside the biliary system will be water, as in high signal. The bile will itself be, you will never convince yourself that this is going out. So you have to do a dynamic cholangiogram. What kinds of dynamic cholangiogram you can do? First, you can do ERCP and there is a leakage there, right? You can also do a nuclear scan, right? But nuclear scans are not available, which can. Now we can also do a scan with this thing, which is Primovist. The concept is that it is excreted by the hepatocytes. And we do a 60-minute delay scan, 60-minute delay. The radiographers don't like it. And on that, contrast can go out. I've done about 15 or 18 cases. I've noted them down. In 3 on 4, we did make a diagnosis. So I don't count it as a magic uh, option, but if because of other factors you cannot do, we have got something. I'll show you a case. You don't believe me. You believe me or you don't believe me? So I let me show you a case. It is a separate PowerPoint. Which one? Bile leak, this one. So this patient was post cholecystectomy and so T2 weighted. Now on T2 weighted, one can argue now this part of the biliary system, the common hepatic duct is not very well seen, but also had a what we call a drain here, and there is some fluid here, but you are not sure whether. So this is a T2 weighted sequence on which you see this is the drain, and there is some fluid here. Now, is this leaking bile? You will never be sure. This is the drain which goes out of the human body. Now, this is a 20-minute delay. The Primovest phase in which you can see something here. You see this thing? 20-minute delay. And so then the learning point here is that we do a further delay, 60-minute delay. On 60-minute delay, do you see this? So this is the right hepatic duct. And now do you see how contrast has concentrated here? Actually, contrast has gone now going into the drain. You can see it here, right? Convinced? But I think out of these 15, I got results in about 4 or so. But still, there is a model, we can do it. You have to really liaise with us because the radiograph, 60-minute delay. So administratively, you are stopping where we are, we do imaging for the whole hospital. So just think like this, in 60 minutes, I can do 4 brain TIA scans or MR of the spine? So which are more important? Okay, you people are asked these. I'm just finishing this session now. This is a hemangioma on a CT scan. This is an arterial phase. Please remember, hemangiomas are two types. Flash hemangiomas, which enhance on arterial phase, are very small. They are less than 2 centimeter or mostly less than 1.5 centimeter. Otherwise, the concept is that the periphery of the hemangioma will enhance. Periphery. And that periphery will show you a puddling of contrast, puddles of contrast. And as you do delayed scan, there is centripetal extension of contrast, centripetal extension. Unless there is a central scar which might not, but it will enhance like that. If you see the CT scan, uh, nothing, no enhancement is there. Then here, I think you can see these puddles of enhancement. Do you see this? And then on a delayed phase, there is centripetal. And do you see how the centripetal extension of contrast is there? Another point to remember that the enhancement pattern will be equal to we use the word blood pool. What is the blood pool? The contrast in the veins. So it will be equal to that. For example, if you see this enhancement, it will be equal to this, right? Now on MR, of course, so this is a contrast ultrasound. And on contrast ultrasound, you can see this nodular enhancement with centripetal extension. The central part is a scar, which has not enhanced. And sometimes there is a small bit of thrombosis inside the hemangioma. So this is a case of on hemangioma on an MR. So one point is that on a T2 weighted sequence, this is the lesion, quite a large lesion, and there is a scar also. It shows restricted diffusion. It is bright on DWI, and I have told you that this is a feature of malignant lesions, except for hemangioma, right? And actually, I think I have the slide I've missed. Yeah, sorry. I missed the post contrast of that one, but I've put in another one here where there is a giant hemangioma which shows this nodular enhancement, and there is centripetal extension of contrast, which has not completely, because this portion is thrombosed. I have put a MR in your workshop cases. Go through it, and you can this one is in DICOM. Okay, this case can potentially come in the exam, and that is why I'm showing you. On ultrasound, this is the appearance, which is a totally non-specific appearance. On CT scan, key point, it is not enhancing. What comes to your mind? But here it was not a cyst. Agreed? Is this a cyst? And it is not enhancing. And this is a young 23-year-old female. And then we have got an MR. On MR, it is not enhancing. What is inside? Septi. So we call them membranes. Membranes. There are membranes there. And these membranes should be in your mind, because these membranes are absolutely, sometimes there are daughter cysts, sometimes this membranes inside. And key point is it will not enhance. So that is what we call hydrated cyst. Last case is just to give you the idea of hemochromatosis, because as gastroenterologist, you ask for iron overload. Please remember the differential diagnosis is hemochromatosis, which can be primary or it can be secondary, a patient who had transfusions, etc. So you ask for MR. We do this MR, we call it iron overload protocol. There are two things for us to give you. One is diagnosis. Is there iron inside? and then is quantification. So in our hospital, we did not have the software to measure the quantification. Only in the last 2, 3 months we have acquired it. So now it's simple. The software tells you what, because the gastroenterologists want to know that if it is iron, what is the quantity, and there is a factor. So we can do it. The key thing is that we do a sequence known as gradient echo sequence. We do 5 sequences. This black thing actually is iron. It's a very specific tool. It can give you that this is hemochromatosis, and we can also quantify. Okay. So what was the schedule? So we have encroached into the break. Yeah. So I'm sorry, I have put cases on the workshop. I don't have time to go through them. Maybe what we can do is, it comes an idea that if you people are interested, I will only be guided by your interest. Email back that you want. What I can do is that I can make a video of the cases. I put in MR liver. I can make a video, screen grab of my, and send it to you if you are interested. If I get 25 emails, so that will be worth it then. So I'll be guided by numbers. Okay. So I'll give you the solutions of it. So whatever I wanted to teach you here, I can teach you remotely. Uh, my suggestion is, we have got a lot of cover. Let's discuss as a group. This course goes till 1600 hours, right? We have got a tea break. Sorry, 1800 hours. We have got only 1 hour something, right? What we do is that, give me another 15 minutes. I will run through the biliary. Take a 15-minute break, not a 30-minute break. And then we will do the pancreas. Okay? Okay or not?
I feel like whether it have enough time.
So we can do a breakdown then.
Yeah, we just continue on.
Oh, it will be good for you to change the, from biliary into pancreas. I'm thinking it like that. I want you to be more attentive. Biliary is very easy. It's spot, tuck, 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 tuck. Rapid fire. Rapid fire. Okay? Go or not? Okay. Biliary. Biliary, 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 biliary. If you see right hepatic duct, left hepatic duct, common hepatic duct, where the cystic duct, then we have got common bile duct. So this is the anatomy. No time to go through this, but as ERCP people, I am sure you and as surgeons are also very worried about normal variants. There are so many normal variants. Variation in extrahepatic bile duct, 20% of the, and this is what you will see in your as for MRCPs, ERCPs, and cholecystectomies. These things should be etched in your brain. And we have got so many cases in our clinical practice where because accessory duct was cut, by the surgeons. So similarly, variation in course and insertion of cystic duct, lot of variation. Look at this one. It is going here. So this is important. On ultrasound, this is that double barrel sign which I was telling you. This is where we measure. This is the CBD. Actually, this is common hepatic duct, but we call it CBD. Some of the purists in radiology, they say use the word common duct. So you common duct. But if you want to be very elaborative, you say extra hepatic biliary duct. It's all semantics. This is the hepatic artery which goes in between. You remember, brothers and sisters. So this one goes through it. Passes through these two. Hepatic artery. This is MRCP. Rapid fire. Which investigation is this? Rapid fire. Do you see this needle? PTC. This is a PTC. The needle is there. In ERCP, there will be a cobra sitting inside. Remember it like this. Please remember PTC can only be done if intrahepatic ducts are dilated. A radiologist will do it for you, right? So this is the needle. And in our exam, this is what we check. What is this? You have to tell me what is this. So rapid fire, what is this? And here the Mr. Cobra is sitting there, your endoscope, right? And what is this? T-tube. T-tube. So if you see this is a T-tube cholangiogram, sometimes the surgeon put in a T-tube and we do a delayed investigation to look for any retained stone health. This is a known T-tube cholangiogram. Sometimes, very rarely, per operative cholangiogram. Do you see this? This is per operative. This is the cystic duct, right? Now, in this T-tube, what is the pathology? Rapid fire. Classical exam case. Say again. Stricture. Something else. Stone. If you see, we call it, this thing, we call it a meniscus sign, meniscus. And T-tube cholangiograms are done post-surgery, and particularly for this kind of a thing. This is a meniscus sign, and a meniscus sign is a sign of stone. This thing, take a picture and take 10 pictures of this. This is everything you want to know for your differential. I have seen loss of enthusiasm in the morning. Too many of you were taking pictures. Now you are. So, yeah. So, if you see here, this tells you everything you want to know on cholangiogram. Let me talk through it and then I'll show you cases. All of this session is about this. If you see a stricture at this level, which is the porta hepatis level, proximal, this is the left hepatic duct, right hepatic duct. This is the common hepatic duct. The differential will be cholangiocarcinoma, which is a Klatskin tumor, versus a carcinoma gallbladder or porta hepatis metastasis, right? If you see in the middle, if you stretch your imagination, Mr. Pancreas is sitting somewhere here. So this can be a cholangiocarcinoma or a pancreatic carcinoma. Distal, this one. Again, pancreatic carcinoma, cholangiocarcinoma, carcinoma of ampulla of water, and a duodenal carcinoma. This is here. On the other hand, the benign ones are very black and white. In this, you will see a shelf-like stricture here. This is post-surgical. Classically, what happened is that in surgery, if they damage it with their forceps or something, then gradually with time, there is fibrosis here, and that stricture will be shelf-life. You remember web in the esophagus, it will be like that. But anatomy tells you what it is. Another benign stricture for your exam is a stricture of chronic pancreatitis. So chronic pancreatitis is distal, of course, intrapancreatic part of it. Okay, same concept on MRCPs, right? Same concept on MRCPs. Okay, what is this? Say again. No, pathology. This is a PTC. There is a stricture here. What is your differential? Cholangiocarcinoma. Excellent. Klatskin. Okay, this is an MRCP. This is the pancreatic duct. This is the CBD. Stricture here. And this is also stricturing the pancreatic duct. What is your differential? And pancreatic carcinoma. Now, there is something here which is causing, we call it the double duct sign. CBD is obstructed and pancreatic duct is obstructed. What is your differential? Yeah, so the four things, right? Cholangio, pancreatic, carcinoma ampulla of water, and duodenal. If you stretch your imagination, one can feel that something is there. Please remember, for ampulla, radiology is rubbish. And we are guided by, we ask you to have a look and a duodenoscopy or whatever. Yes, what is this? So post-surgical, right? Iatrogenic stricture. This is the classical location, right? So they have, damaged it, and later fibrosis developed. The surgeons don't agree. They cannot do this. No way. No way. So if you see here, yeah, and why is it chronic pancreatitis? If you see, there is calcification, and this you will see tapering of the stricture. So this is chronic pancreatitis. What is this? No, this black thing. There is a sign, Mercedes-Benz sign. So, stones can be cholesterol stones, which are fat. And they can have this kind of a shape, which is known as Mercedes-Benz sign. And please remember the concept, as somebody correctly pointed out, that in acute pancreatitis, our role is to do an ultrasound, because ultrasound is the top modality, much better than CT, to pick up stones. Calcified stones can be seen on CT, otherwise it's rubbish. So ultrasound is the investigation of choice. Look at this, ultrasound 95%, CT 70 to 80. I don't think so it is 80. I think it is less than that. MRCP, you see this sign here is meniscus sign. Once again, meniscus sign. And you can see that there are multiple other stones. Sometimes stone with calcification can be seen within the biliary system. Here is an example where you can see intrahepatic duct dilatation, and you can see this stone. For this, on MRCP, there is a meniscus sign, right? Adenomyomatosis. You will see it in our reports. These are hyperplastic cholecystosis. And on ultrasound, there are two types of adenomyomatosis. One is known as, two types of cholecystosis. One of them is known as adenomyomatosis cholestatrosis. Key point to remember that these are benign entities, no malignant potential. This is key point for you. The literature tells us that uh, at times you miss it because a carcinoma can be with it. But now with imaging, we are so good. But I just label it. I never say that do a follow up or I cannot rule out, because what you do is if you pick it up on an ultrasound or CT, ask for an MR, and you can be absolutely black and white. But if you are experienced, you can be on ultrasound. This is black and white finding. We call it comet tail artifact in cholesterolosis, which is one of them. So if I do it, I will not ask for any. Don't confuse it with, let's say, a polyp, which is a different entity. I'll come back to polyps. But key point is that when we say that this is adenomyomatosis, believe us, forget about it. If we have got doubts, and sometimes on CT we have got doubts, we will say next image. Another thing is gallbladder polyp. So polyp is a big subject, and key point for you to remember is that the guidelines are where you are working, but the guidelines usually in our hospital are these are the European guidelines. Anything which is more than 1 centimeter, get rid of it. Elective cholecystectomy. And if the rate of growth is more than 4 millimeter in an year, get rid of it. But these are the take-home points. Otherwise, there is a lot of it. Acute cholecystitis, there is nothing much for you to see. Okay, so this is a carcinoma gallbladder. And do you remember that the levels? In this case, also, this is a proximal duct, right? Common hepatic duct. So carcinoma gallbladder does this. That from the gallbladder, it goes into into this territory. So it will be in the differential diagnosis. What is happening? Classical exam case. There is a filling defect here.
Yeah.
Stone. So why is it causing dilatation of the CBD and intrahepatic duct dilatation? Maritzi's syndrome. So in Maritzi's syndrome, what happens is that a stone sitting in the cystic duct or a large stone sitting in the neck of the gallbladder, it compresses the CBD and causes obstruction. But in surgical literature, there are subtypes. And what happens is that gradually this actually erodes into the CBD. So portion of it will erode, and there are a lot of type 1A, B, C. For me, that is irrelevant. But the main thing is that you should know that this is Maritzi's syndrome, right? I'll show you another one. This is an MRCP of a Maritzi's. Do you see that half of the stone is sitting in the cystic duct and the second limb is sitting in the CBD? So it has eroded that one also. Maritzi's is exam. What is happening to this gallbladder? Porcelain, I don't like it. You know, porcelain means calcification, which is high density. Is it high density? You see the wall. So this is mural. This is emphysematous cholecystitis. This patient will present to you with, diabetes with this. Very serious. Emphysematous cholecystitis. And the same thing here on a CT scan. This is a different case, but this is ear. Ear can be in the lumen and ear can be in the wall. On the other hand, this is what somebody was talking about. Porcelain gallbladder. What will you advise? Classical exam question. Cholecystectomy, because there is a rate of malignant transformation. I read about it once, and all of the studies which show us this are these are 15, 20 years old. The latest studies in the last 10 years, not a single study has proved that this is pre-malignant. But still nobody is brave enough to change it. I think we are heading towards that. In any case, you should remember that this is porcelain gallbladder, and you have to say that I will advise a cholecystectomy. And this is a porcelain gallbladder on a plain film. Okay, what is your differential? Oh, this is a classical porta hepatis tumor, intrahepatic duct dilatation. So this is Klatskin tumor versus a carcinoma gallbladder. That will be, again, the same concept arises. Okay, new world. And I think this is the end of it, but this is 4 or 5 cases. Now, in this particular case, 27-year-old, right upper quadrant pain, intrahepatic duct dilatation, and then what is this? Can you imagine? This is the CBD. This is the CBD. Gallbladder is sitting here. 27. Intermittent jaundice. Sometimes it develops, sometimes it is fine. 27. What comes to your mind? Choledochal cyst. This is the ultrasound of the same patient. You see this? How much is the dilatation? And this is an MRCP. And here you are. Right. Classic. Now, this thing should be absolutely in your mind. It is Dodani classification of choledochal cyst. It is something congenital. And there are 3 cysts which are exam cysts. Other ones are rubbish. But the one is, if you see, this is also classical example of the eye see what the mind knows. If you don't know it, you are never going to diagnose. So the type 1 is that this one, type 1 is extrahepatic biliary duct is dilated. Type 2, forget it, don't concentrate here. Type 3, this is interesting because there is a cobra head type of appearance, a choledococele. I'll come back to this one. Type 4, where intrahepatic as well as extrahepatic. And type 5 is only intrahepatic duct. Type 5 is also known as Crowley's disease. For your exam, remember type 1, remember type 3 and type 5. Type 1, 3 and 5. And let me show you. This is once again type 1, just like the case which I showed you. You see, extrahepatic bile duct is dilated. Then look at this appearance, choledococele, where there is a bit of this dilatation. Look at this appearance. We call it the cobra head appearance or the adder head appearance. Do you see this on MRCP? There is a choledococele and there is a stone also. So cobra head versus adder head. What do you think? This is an adder or a cobra? Cobra. Yeah, cobra. So this one is a dilatation of extra and intra. I don't worry about. But this one you should know. This is Caroli's disease, intrahepatic duct dilatation. Do you see this on ERCP? That there is intrahepatic duct, and do you see that there are cystic dilatation of this? On a CT, even here, you can see that there is a cyst which communicates with this intrahepatic duct. There is a sign in radiology known as central dot sign. Because of anatomy, you remember the bile duct, you know the brothers and sisters, portal triad, portal vein, hepatic artery, and the bile duct. Now this brother is dilated, and in the center is the sister, which is the hepatic artery, right? So this is known as central dot sign. There is no cyst which will appear. So I can give you this in the exam. You'll say, oh, this is a cyst. Look inside. There is an enhancing vessel. So that is why it becomes an exam case, right? This is Caroli's disease. And finally, what do you think is this? You know, these cases will have hundreds of small cysts, hundreds of cysts. Hundreds of cysts. Give me the diagnosis. Autosomal dominant adult polycystic liver disease is a separate entity. Those cysts will be large. These ones are, yeah, excellent. The something is this one. Multiple biliary hematomas, von Mienberg complexes. This is, at times they cause a bit of symptoms, but usually it's a benign thing. You don't do anything about it. Don't confuse it with multiple big cysts, which is a different word, which can happen with autosomal polycystic kidney disease. But what we are talking about, adult or autosomal hepatic disease, right? That's a separate entity. The cyst will be large. This one is hundreds of cysts. They are very small. And these are known as biliary hematomas. What is this? PSC. If you see here, look at the bile duct and look at the, it is irregular. There is stricturing. There is nodularity. And look at the intrahepatic ducts. They are similar. So this is PSC, as in primary sclerosing cholangitis. You can also see it here. You can see enhancement on a CT scan. You have to differentiate it with autoimmune cholangitis with IgG4 related disease. So without overloading you, just a few clinical points you have to remember. Clinical points are that in PSC, the age of onset is young, 30 to 40. Majority cirrhotic within 10 to 15 years, and most likely association with IBD. And there is a risk of cholangiocarcinomas developing. IgG4 related disease, on the other hand, is 5th to 6th decade, and it can be with autoimmune pancreatitis, and there are other stigmata of IgG4 related disease also, but you will not have malignancy. Look at this pancreas. This is an exam case. There is loss of what we call pancreatic folia. It looks very smooth, and sometimes you will see a bit of rim around it. You see this thing? Sausage shape, comma shape. What comes to your mind? Autoimmune pancreatitis. So In your exam, they can show you an autoimmune pancreatitis with the, the cholangiopathy, where there is enhancement also. Okay, thank you. So I again went beyond the 15 minutes. In any case, this was easy, but these are all exam cases. These are rapid fire. These are easy. Now, let's have a bit of a discussion. It is 8 past 5. Can we convene in 12 minutes from now? How many of you? Yes. Good. So at 5:20 we are meeting. Pancreas.